Bismillah ar-Rahman ar-Rahim. This is a talk about non-statin therapies in atherosclerotic cardiovascular disease. I will be with you, Ahmad, Samir from Cairo University and Aswan Heart Center. We have a wide roadmap for the lipid modifying agents that can be utilized in atherosclerotic cardiovascular disease. Some have been approved by FDA and EMA, some were withdrawn from the market, some have been gone through phase 3 and some failed to go. For dietary cholesterol, or what we can call exogenous cholesterol particles that come from the diet, when it reaches the intestinal lumen, it will interact with a Niemann-Pick C1-like 1 protein that is present along the brush border or the enterocytes border, which facilitates its absorption from the intestinal lumen into the enterocytes bodies. There, it will have some interactions, then it will be combined with the absorbed triglycerides, facilitated by the MTTP to form the chylomicrons that will complete its journey into the bloodstream, then the liver. In this diagram, which is a bit wider, the previous slide is represented in the lower left part of this one. There is the intestinal cell, the brush border, and the absorbed triglycerides and exogenous cholesterol into the enterocyte. There we form the chylomicrons that is transferred into the lymphatics of the intestines, then into the bloodstream, then into the liver. I just need you to focus from this overcrowded screen that we have the transfer of the chylomicrons, then the endogenous or the other source of cholesterol that is formed inside the hepatocytes will be transferred into the circulation as the VLDL particles, which is the grandmother for the LDLs. The VLDL will go through its interactions and exposed to multiple metabolic pathways and steps. Then it is transformed into IDLs. Some of them go directly to the liver. Some of them are transformed into the LDLs particles that we know. And there is another reverse cholesterol transformation journey that comes from the extrahepatic cells to the liver cells over the HDL particles. This slide being that overcrowded, but we need to know the hinge points or the Achilles points that we target for medications. The MTTP that is required to compose the cholesterol and the triglycerides into the lipoprotein particles, which is in the intestinal cells, pushed onto the ApoB48 to form the chylomicrons, while in the hepatocytes, they are formed with the ApoB100 to form the VLDLs. This MTTP can be directed with a drug being inhibited. This will cause reduction of the lipid components into the blood. Similarly are the Niemann-Pick C1-like protein. Similarly will be the endogenous cholesterol synthesis into the liver. And this is why we need to be familiar with the lipid metabolism to understand how we can target and to reduce the cholesterol levels in our circulations. This is another diagram. Here we know that cholesterol, either exogenous or endogenous, can be utilized for the formation of bile acids. Bile acids are secreted from the liver through the bile into the intestinal lumen, where they have a very important role in the absorption of lipids and lipid-soluble vitamins. The majority, around 97% of these secreted bile acids, can be reabsorbed through what is named the enterohepatic circulation back to the liver to repeat the role. This is another target where we can have some agents that prevents the reabsorption of the bile acids to deprive those returning bile acids at the hepatocytes. Thus, the hepatocytes will feel hungry for bile acids and utilize more and more cholesterol to renew and form new bile acids. While the acetate into cholesterol pathway, and this is composed of many steps and many enzymatic actions, we can inhibit this pathway to form the endogenous or the already formed inside the hepatocytes cholesterol to reduce the cholesterol levels in our circulations. So we have the HMG-CoA reductase inhibitors, we have the bombidoic acid that we will discuss shortly, and we have the bile acid sequestrants, to inhibit the reabsorption of the bile acids through the enterohepatic circulation. This represents what we say targets of therapies that we can use. Now we can roll over some of the agents that we need to put some emphasis on. The ezetimibe is essentially acting to inhibit the Niemann-Pick C1-like 1 protein. Thus, it inhibits the absorption of the exogenous cholesterol at the brush border. This will limit the delivery of the dietary cholesterol to the hepatocytes, and the hepatocytes will feel hungry for more cholesterol. Accordingly, it will compensate for by increasing the expression of the LDL receptors and take up more and more LDL particles from the circulation through those increased LDL cholesterol receptors. Accordingly, ezetimibe as a monotherapy can cause something around 22% LDL reduction. In a large meta-analysis on real practice, it causes 18.5 reductions in LDL cholesterol, causes 8% reduction in triglycerides, 13% reductions in total cholesterol, and 3% increase in HDL cholesterol levels. The PCSK9 inhibitors. First, to know the proprotein convertase subtilisin caxin 9, the PCSK9 molecules are present in our bodies, circulating in our circulations and present in the hepatocytes, where they binds with the LDL receptors, mediating its lysosomal degradation for renewal of the receptors. And we find that people and populations with natural genetic mutations with loss of function of those PCSK9 molecules, they have lower LDL levels and reduced atherosclerotic cardiovascular disease levels. And thus, we have developed monoclonal antibodies that can bind and inhibit PCSK9, like the evolocumab and the alirocumab. Accordingly, they can cause more LDL receptors to be available and more hepatic clearance of circulating LDL cholesterol particles. They are taken by subcutaneous injections. Accordingly, pain and allergy at the injection sites plus influenza-like manifestations are the main adverse effects. The newer compounds like evolocumab and alirocumab are human monoclonal antibodies, while the older, the bococizumab, was a humanized, and it failed to be propagated into our current practice because there was high failure rate for neutralizing antibodies that our bodies forms against it. For being at high cost and no significant improvement on cardiovascular mortality, they are limited for being used widely, and they are spared currently to very high risk for secondary prevention or familial hypercholesterolemia cases. Bile acid sequestrants, on the contrary, are large molecule resins that are taken orally with no systemic absorption. They are not systemic from the GIT lumen into our systemic circulations. They bind with the secreted bile acids in the intestinal lumen and inhibit the absorption of the drug bile acid sequestrant complex into the terminal ileum, thus interfering with the enterohepatic circulation. The decrease of bile acid molecules returned to the liver makes the liver hungry for bile acids and utilize more cholesterol, either exogenous or endogenous source, for formation of new bile acid molecules, and thus increase the hepatic uptake of the circulating LDL cholesterol to feed and compensate for those deficient bile acids. Bile acid sequestrants generally are old agents and were tested before the current new agents have been available. The major adverse effect is GIT intolerance, increase in triglycerides, and potential risk for increased pancreatitis. The bile acid sequestrants interfere with absorption of fat-soluble vitamins, the ADEK complex. Bile acid sequestrants, lastly, are the only agents allowed in pregnancy because of the character of have no systemic absorption whatsoever. Then comes the omega-3 fatty acids, and the most popular of them, the icosapent ethyl. It decreases the VLDL particles and thus reduces the LDL cholesterol and triglyceride levels in our circulation. The exact mechanism of the omega-3 fatty acids is not fully understood, but mostly through interaction with the PPAR gamma pathways and decreased secretion of ApoB particles. The REDUCE-IT trial is a major trial studying the cardiovascular effects of icosapent ethyl, and it proves that there was 25% relative risk reduction of major adverse cardiovascular events. The bombidoic acid, a relatively newer agent, is essentially an ATP citrate lyase inhibitor. Through the production of endogenous or already in our bodies made cholesterol particles, the activated metabolite of bombidoic acid is in the chain of the generation of cholesterol ring, but is upstream by two enzymatic steps than the statins that we use nowadays. It requires a very long chain enzyme that is named acyl-CoA synthetase, very long chain type 1 enzyme for its activation from the inactive component, the bombidoic acid that we take, into the active metabolite. This particular enzyme that is required for its activation is deficient in the skeletal muscles, and thus, having this enzyme absent in the skeletal muscles, there is no active metabolite of the bombidoic acid, the active component that is functioning in the skeletal muscles. And accordingly, bombidoic acid is not capable of causing any of the skeletal muscle side effects seen with the statins. Bombidoic acid has been recently approved by FDA. It causes 29% extra reductions of the LDL cholesterol when added to ezetimibe, 18% reduction when added to maximum tolerated statins, and 20% reduction of LDL cholesterol levels when used as a monotherapy. The fibrates are peroxisome proliferator activated receptor alpha. They have a critical role in regulating lipoprotein metabolism and reducing the triglycerides by around 50% and the LDL cholesterol by about 20%. The very old agents, gemfibrozil, was hated and put down for the GIT intolerance and extensive drug-drug interactions with a very high rate of inducing myopathy when combined with the statins, which is obviously a very required combination to be used and practiced. The fenofibrate, the newer agents, are generally more tolerated with less side effects. Fibrates may increase the serum creatinine, but this effect is often very reversible after drug discontinuation, and increase homocysteine, which is particularly incriminated that it might have been mitigating their cardiovascular benefits. The other drugs that are essentially used for the homozygous familial hypercholesterolemia and thus used with expert consultation from lipidologists are lomitobide and mibomersin. Lomitobide is taken orally. It acts to inhibit the microsomal triglycerides transfer protein, which is required in the hepatocytes to form chylomicrons for the absorption of lipids, and in the hepatocytes to form the VLDL, the grandmother for LDL cholesterol particles. And thus it inhibits lipids absorption and lipids release from liver into the blood. Lomitobide is known that it is capable of decreasing the LDL levels by 50%, and in homozygous familial hypercholesterolemia cases, it reduces the apheresis sessions need. However, the adverse effects are steatorrhea and GIT intolerance when it inhibits the absorption of lipids from the intestinal tract, and steatohepatitis and transaminitis for accumulating liver particles and components into the liver and preventing their release into the circulation. On the other hand, mibomersin is taken by subcutaneous injection. It is an antisense oligonucleotide, which means that it is a small molecule that inhibits and binds the messenger RNA for ApoB100 lipoprotein. It inhibits the formation of VLDL inside the hepatocytes. It significantly reduces LDL cholesterol levels and lipoprotein little a levels, and its adverse effects is essentially liver toxicity and reaction at the injection site. Another agent that we are awaiting in the near future is volanesorsen. Volanesorsen is an antisense oligonucleotide that binds and inhibits to the messenger RNA of ApoC3. ApoC3 normally inhibits the lipoprotein lipase, which hydrolyzes the triglycerides into its initial parts. And thus, by inhibiting ApoC3, we augment the effect of lipoprotein lipase. Volanesorsen is awaited to be an essential part of the treatment for familial chylomicron syndrome. Now, for the practical part of this lecture, When you have a patient who is not in target after lifestyle and maximum tolerated statins, what is the next step? What should be the next step? First, we need to know, all of us, that there is always something to improve in the lifestyle interventions. We should intensify the lifestyle advices and interventions that patients have and give them where we can improve his life and styles. Second, we can all read the guidelines. We will not go through it, but I will give you just tricks. Definitely, statins comes as a first option and class 1 with level of evidence A as a lipid-lowering agents. Then, ezetimibe will usually be class 1 to take as the best second agent beside statins. PCSK9, you will never find it as class 2A. It will be as class 1 in certain conditions and class 2B then whatever else. These conditions will be if a patient who is for secondary prevention and did not achieve targets after maximum tolerated dose of statins and ezetimibe, the first one. And the second will be for a patient who has familial hypercholesterolemia and is considered as a very high risk. And we will see this right now. So ezetimibe will be class 1 to be added in combination with the statins if upon statins and lifestyle interventions we did not achieve the targets. For primary prevention, which does not qualify any of the two conditions that we stated for PCSK9 to be class 1, PCSK9 will be class 2B besides statins and ezetimibe. For secondary prevention, after statins and ezetimibe, we will find PCSK9 inhibitors as class 1. For familial hypercholesterolemia, classified as very high risk, like having an atherosclerotic cardiovascular disease before or having another major risk factor besides the familial hypercholesterolemia, PCSK9 inhibitors besides statins and ezetimibe will be class 1. Ezetimibe will be class 2A, Ezetimibe will be class 2A as a replacement for statins, the first agent, if statins are not tolerated at all after a rechallenge. And adding PCSK9 besides ezetimibe will be class 2B. Bile acid sequestrants will be class 2B to add after statins or besides statins if not achieving target. And we all know that it is essentially required in special situations. The omega-3 fatty acids, the icosapent ethyl, will be class 2A to be added if besides statins, the triglycerides remains between 135 to 500. For primary prevention, fenofibrates and bezafibrate can be utilized besides statins if the triglycerides are still above 200. And lastly, fenofibrates or bezafibrates can be used for the same thing in very high-risk patients or in high-risk patients besides statins. Again, to the roadmap that we established in the early beginning, I want you to go through this slide slowly just to find where each agent targets the lipid metabolism at which part of its journey from ingestion till the circulation. Now with questions, just to refresh what we have learned from our talk. Mr. MH is a 57 years old man with previous PCI because of unstable angina. He has type 2 diabetes mellitus. He visited your clinic. He had non-HDL cholesterol of 93 milligrams per deciliter. Non-HDL cholesterol. He is on atorva 80 milligrams per deciliter. What is the next step? Would you accept this level and just give lifestyle advice and ensure compliance? Or would you replace atorva with PCSK9 inhibitors? Or would you add ezetimibe 10 milligrams to the current therapy? Or add PCSK9 inhibitors to the current therapy? I believe the best answer is adding ezetimibe 10 milligrams to the current therapy because the non-HDL cholesterol target for those at very high risk, because he is for secondary prevention, is below 85 milligrams per deciliter. And thus, the best second agent is ezetimibe after the maximum tolerated statin dose, which is he is already on. Question number 2. After the previous step for Mr. MH, he achieved the required LDL-C target. However, his triglycerides remained above 165 milligrams per deciliter. Is there a room for any improvement? Would you put him on combination of statin, ezetimibe, adding PCSK9 as a third agent, or add icosapent ethyl 2 grams by BID or twice daily to his regimen, or combine with bile acid sequestrant? Or this LDL cholesterol you are happy with because it is the primary target and other parameters have minimal effect on the cardiovascular outcomes, i.e. you can leave him as is. The correct answer is adding icosapent ethyl to his regimen because it is class 2A to add icosapent ethyl for high and very high risk patients if their triglycerides remained between 135 to 500 after you have achieved the required LDL targets. Mrs. AG is a 32 years old lady with type 1 diabetes for more than 20 years. She has LDL cholesterol of 163. She is contemplating pregnancy. What would you prescribe for her? Rusuva 10, Atorva 40 plus ezetimibe 10, or bile acid sequestrants? Okay, bile acid sequestrants are the only agents approved during pregnancy because they have no systemic absorption. Question 4. All the following regarding bombidoic acid are correct except that it is currently FDA approved for atherosclerotic cardiovascular disease and familial hypercholesterolemia. Bombidoic acid has the same potential skeletal muscle-related adverse effects as statins. Bombidoic acid reduced LDL cholesterol by 18% when added to maximum tolerated statins and by 22% as monotherapy. And bombidoic acid is a prodrug that requires hepatic activation. The correct answer is number 2, because the activating enzyme for bombidoic acid is not expressed in skeletal muscle fibers. Accordingly, this agent is completely free, theoretically, from skeletal muscle adverse effects that are present in statins. Question 5 and last, the PCSK9 inhibitors are characterized by the following except evolocumab and alirocumab clearly reduced cardiovascular death in their respective trials. They are currently approved in primary prevention for heterozygous familial hypercholesterolemia at very high risk. They are expected to reduce LDL cholesterol by more than 65% versus placebo. They are available in subcutaneous injectables form. The answer, which is not correct, that they did not reduce cardiovascular death in their respective trials, in the Odyssey for Evolo and Fourier for alirocumab. Thank you. Hope you have enjoyed our lecture.